Okay, let's unpack this.
Right.
For this deep dive, we're focusing on what is, I think we'd both agree, arguably the most challenging and complex patient population in the entire emergency department.
Without a doubt, the elderly.
Exactly. We've got a pile of expert clinical guidance here, really high-yield stuff that you can't just memorize, you have to. You have to synthesize it.
That's the key word, synthesis.
So our mission today is to take all this critical knowledge and turn it into something immediate, something actionable, basically a senior clinician's guide for our colleagues and trainees on the floor.
That's it, exactly. We want to cover geriatric presentations comprehensively, but more than that, we need to bridge that gap between the textbook theory and the sheer chaos of real-world practice.
Yeah, that's a good way to put it.
We have to be explicit here. This is a special patient group, and if you fail to recognize their unique vulnerabilities, physiologically, socially, that is one of the fastest ways to miss a life-threatening diagnosis.
And lead to some really avoidable morbidity and mortality.
Precisely.
And the numbers just, they bear this out. The geriatric patient is just different. The sources all emphasize that comorbidity isn't the exception, it's the rule.
Oh, absolutely. They often come in with multiple underlying problems. Sometimes 10 or more things all interacting in ways you just can't predict.
It's not a list of diagnoses, it's more like a house of cards.
It is. And one small stressor can bring the whole thing down.
And you can't separate the medical from the social. The sources are so clear on this. These patients are often living in, let's say, socially precarious situations.
Yes, their support system, or the lack of one, has a huge impact on their baseline function, their ability to get care, and, this is the critical part, their safe discharge plan.
Absolutely. Then you layer on top of all that something like Alzheimer's or just chronic confusion.
Right.
And that requires a whole different approach right from the moment they walk in the door. It affects everything.
So this deep dive is all about equipping you, the listener, to quickly recognize those really subtle, atypical presentations, the disguises that severe illness wears in this group.
And to mitigate the common pitfalls.
Which are everywhere. And ultimately to deliver safe, high-quality care when you're under pressure.
Okay, let's start where the patient starts. Right at the front door. Triage and initial assessment.
Good place to start.
For an elderly patient, the idea of urgency seems a lot more fluid than for a healthy 40-year-old. Why do the sources stress that triage here is so dynamic?
It really all comes down to one thing: physiological reserve. Or, more accurately, the complete lack of it.
They just don't have that bounce back.
Exactly. A younger patient can compensate for an acute illness in dramatic ways. They'll spike a huge fever, their heart rate will shoot up. The older patient, their reserves are minimal.
So their urgency can change in an instant.
In an instant. They run out of coping mechanisms much, much faster. The patient who looks sort of okay in the waiting room could be crashing in 30 minutes if you miss one subtle sign. Their triage category should always be considered, unstable.
Which means we can't just rely on our gut or waiting for them to collapse. We need objective tools. What should we be using?
We have to rely on standardized tools. Something like the NWS2 score, the National Early Warning Score.
Why is that so useful here?
Because it forces you to look at the subtle things. It formalizes the assessment of, say, a slight increase in respiratory rate, or a small dip in oxygen sats, or a change in their mental state.
Things you might miss if you're just looking at the blood pressure.
Exactly. A score of just 2 or 3 in this population means a significantly higher risk of mortality. And it's not just a one-off score on arrival.
You have to keep checking it.
You have to. If that NWS2 score starts climbing from 0 to 3 while they're in a bay, you have to escalate immediately, even if the patient is sitting there telling you they feel okay.
Okay, so before we move even an inch past that initial assessment, there's a rule that the sources just hammer home. It's a non-negotiable.
I know where you're going with this. Pain.
Pain management. The rule is never ever delay analgesia. Why is this still such a sticking point?
It's both inhumane and clinically indefensible. This whole idea that we need to hold off on pain relief because we might mask the signs.
Right, the old surgical fear of masking an acute abdomen or a fractured hip.
It is explicitly rejected in all modern guidance. That's just old dogma that does not stand up to scrutiny. It's wrong.
So if the rule is so clear, why do we still see this happen? What's the psychological barrier, especially for junior staff?
I think it's fear. It's fear of missing the diagnosis, or fear that you're somehow going to bias the next person's examination.
Right.
But we need to be actively teaching the opposite. Diagnosis is often easier once pain is relieved. Think about it. A patient in agony can't give you a coherent history.
They can't cooperate with an exam. They can't tolerate you palpating their abdomen.
Of course not. You give them appropriate analgesia, you improve their compliance, you relax their muscles, and you gain their trust. You get a much more reliable physical exam. Treating pain isn't a barrier to diagnosis, it's a step towards it.
That's a great way to frame it. Okay, so moving from physical pain to, well, the relational complexity of it all. History gathering. This has to be one of the toughest clinical tasks we face.
It really is.
The sources point out that many elderly people will just insist they can cope at home, even when it's obvious they can't. Why do they do that?
For very human reasons. It's fear. Fear of being put in a home, fear of losing their independence, or sometimes just a genuine lack of insight into their own decline.
So you get the patient who insists they just tripped over the rug.
All the time. The rug slipped or the cat got in my way. You have to treat that claim with, well, with immense skepticism. You're basically an investigative journalist at that point.
Which means you absolutely have to go beyond just talking to the patient. You have to get that context from their GP, from community services. What are we trying to find out from them?
We're looking for their baseline. Not just how they are today, but how were they 2 weeks ago? What was their cognitive function like then? Any new meds?
How often was the community nurse visiting?
Exactly. Did that nurse notice they were struggling to get dressed or make meals before this acute event? That collateral information is often the key to understanding what's really going on. It's invaluable for making a safe decision about whether they can go home.
And the presentation itself, it's so often deceptive. This ties back to the whole blunted response thing.
This is a cardinal rule. We have to be constantly on guard for atypical presentations. It's because of something called immunosenescence.
The natural decline of the immune system.
Right. And it means their body just can't mount that classic textbook inflammatory response that we're trained to look for. So the sources warn us signs of infection can be completely masked.
So no fever.
Temperature is rarely increased in a septic elderly patient. In fact, if they do have a fever, it often means the infection is incredibly severe, just overwhelming.
And what about the labs we rely on, like the white cell count? Just as tricky.
Just as tricky. An elevated white cell count might not be infection at all. It could just be reflecting ketonemia, say, in a patient with DKA.
So the ketones themselves are causing a stress response.
Precisely. A false flag for bacterial infection. So without a reliable fever, or WCC, we're forced to rely on much more subtle, non-specific changes.
Like?
A change in mental status, a sudden loss of appetite, or just functional decline. If the patient has simply stopped walking or is suddenly incontinent, you have to assume infection until you've proven it's not.
Okay, so we've gathered this complex history, we've started our workup, now we have to document it, and the sources make a clear distinction between ED notes and a full ward admission note.
Yes, and this is important for efficiency. Our ED documentation needs to be laser-focused, practical.
What's the core focus?
The key issues for the first few hours. The history of the presenting complaint, the investigations you've done, a list of your possible diagnoses, and the immediate treatment plan you started. That's it. Be succinct.
We can leave the 10-page comprehensive clerking to the ward teams.
Exactly. They have the time and space to do that once the patient is admitted. Our job is to stabilize and hand over the critical, time-sensitive information.
But when it comes to discharging a patient, that's when the documentation has to become meticulous.
Meticulous is the only word for it. It's for quality of care, and frankly, it's for medical legal protection.
What specifically needs to be in there?
You have to document all the specific instructions you gave, not just to the patient, but to any relative or friend who's with them. That means precise follow-up arrangements. Who, where, when.
And the red flags?
Most importantly, a clear, explicit list of red flag features that should make them come back sooner. Things like uncontrolled pain, new confusion, persistent vomiting. If you don't write it down, it was never said.
And for the handover when we're admitting someone, what are the absolute must-haves in those notes to ensure a safe transition?
The notes have to be complete and legible, obviously, but they must include a full list of all the investigations you've performed and all the results you have back.
But here's where it often falls down.
Yes, the crucial part. You have to explicitly list the outstanding investigations, what's still pending. Is the second troponin result due? Is that CT report still provisional? Be crystal clear.
And then what you've done and how they responded.
Exactly. Summarize the treatment you've given, the fluids, the antibiotics, and what the patient's objective response was. And one more thing. We should really push for inpatient specialists who reviewed the patient in the ED to write their plan directly in our notes. That creates total continuity.
That's a great point. That single note can prevent so much confusion and delay for the receiving team.
Absolutely.
All right, let's move into section 2. This is where it gets really interesting, digging into the most deceptive presentations, the atypical syndromes. Let's start with acute confusion, or delirium.
Delirium.
Never.
It's probably the most common, the most complex, and the most frequently missed geriatric emergency there is.
How do we define it precisely?
It's an organic brain syndrome. It's characterized by a disturbed level of consciousness and mood, which leads to this global disturbance of their cognition.
And the key features?
Rapid onset and a fluctuating course. That's the hallmark. They can be perfectly lucid 1 minute and then completely disoriented the next. And it's often much, much worse at night. Sometimes their whole sleep-wake cycle just flips.
So the second we suspect delirium, the detective work begins, and the sources emphasize what they call the coexistence rule.
Yes. You can never stop looking after you find the first potential cause.
Why not?
Because in this population, several causes are almost always coexisting. You can't just find the UTI, treat it, and assume you're done. You have to work through a whole checklist of factors.
And where do we start that checklist? What's the most insidious cause?
You start with prescribed medications. This is so important and so often overlooked when we're fixated on finding an infection.
So give us the usual suspects. What drugs should immediately be on our radar?
Well, the list is long, but the big ones are high-dose analgesics, especially opioids, diuretics, which can cause dehydration or electrolyte problems, and then any drug with anticholinergic properties.
Which is a huge category.
It's huge. It includes a lot of antidepressants, older antihistamines, some drugs for Parkinson's. You also have to look at cardiac meds like digoxin and even old H2 blockers like cimetidine. You have to review that med list for any change in the last week. A new drug, a dose increase, anything.
Okay, so after meds, we pivot to infection, and we're back to that blunted response we talked about. The classic example is the UTI.
It is. The body just swaps out the classic symptoms for cognitive dysfunction. But beyond infection, you have to rule out the immediate, critical, and easily fixable things instantly.
Like what?
Hypoglycemia. It's a killer and it's fast. Head injury. Even a minor bump that caused a slow, silent subdural bleed. Hypoxia from a PE or pneumonia. A postictal state after a seizure no one saw. And this is a big one. A distended bladder, acute urinary retention.
That can cause profound delirium.
Absolutely. And it's so simple to fix.
So this whole systematic assessment directly informs our first actions. If you walk into a room with a newly confused elderly patient, what are the immediate life-saving things you do?
The assessment is the treatment plan. First, you get a GCS, even if it's a rough one, and you immediately do a bedside blood glucose check, a BMG.
Or if it's low.
You treat it. Now, you don't wait for the lab to confirm it. And if there's any history at all of alcohol use, malnutrition, any kind of general frailty, you have to be thinking about Wernicke's encephalopathy.
So you give thiamine.
Immediately. Slow 5-ethylamine, it's a completely preventable cause of permanent brain damage. You have to give it.
Okay, so if delirium is deceptive, sepsis is just plain lethal, especially when it's hidden. We cannot overstate this. The classic signs, fever, rigors, high white count, they just might not be there.
They're often not there. Their inability to mount that robust inflammatory response is their key vulnerability. So instead, you have to look for subtle signs of organ dysfunction.
And who's most at risk?
The sources are clear. It's more common at the extremes of age. And it's especially dangerous in patients with comorbidities that mess with their immune system. Uncontrolled diabetes, renal or liver failure, or any kind of immunocompromised chemo, long-term steroids, you name it.
So to screen for this quickly, without a temperature, we use the quick SOFA criteria, the QSOFA.
It's an indispensable tool in a busy ED. It's designed to be rapid and to trigger an immediate response.
So break it down for us. What are the criteria?
It's simple. You score 1 point for each of 3 things, and if the patient scores 1 or more, you start the sepsis 6 bundle right away.
And those 3 things are?
A respiratory rate of 22 or more, a systolic blood pressure of 100 or less, or an altered mental state, meaning a GCS that's lower than their known baseline.
And that high respiratory rate is often the first sign, isn't it?
It's often the earliest and most reliable sign of that underlying metabolic stress. It's a huge red flag.
So once you hit that QSOFA trigger, the 1-hour clock starts for the sepsis 6. It's easy to list them off, but what are the practical barriers in a chaotic ED that slow us down?
That is the crucial question. It's easy to say oxygen, cultures, fluids, antibiotics, lactate output, but the friction points are always IV access and getting that urine output.
The veins are just shot.
Often, yes. So if you're struggling to get a line, don't waste 15 minutes, call for help, get the ultrasound. And second, Putting in a urinary catheter is critical for monitoring, but it can be hard in an agitated, delirious patient. We have to prioritize it as a life-saving intervention.
So to recap the bundle, give oxygen, get blood cultures before antibiotics, push IV fluids, give broad-spectrum IV antibiotics, measure lactate and monitor urine output, and call for senior help or ICU early.
Yes. And with those fluids, the goal is rapid but controlled volume. You might start with a 500 millivol bolus of crystalloid and titrate up, aiming for a MAP over 65. But this is a huge but. You have to be so careful with the speed.
Which leads us perfectly into our next topic, cardiac and pulmonary presentations.
Exactly.
Like sepsis, these often wear a disguise. We see very atypical presentations of an MI in the elderly. What do they present with instead of that classic crushing chest pain?
They often substitute pain for what we call vagal symptoms. So instead of chest pain, they might just have sudden shortness of breath or profound nausea and vomiting, or just new onset weakness or an unexplained faint.
And the really dangerous one, the abdominal presentation.
That's the one that can really trip you up. Abdominal pain, especially epigastric pain, must always make you think about a serious medical problem, including an MI, particularly an inferior wall MI.
And the sources also warn us that an aortic dissection can look just like an MI.
It can, and the outcome is devastating if you miss it.
Yeah.
The classic story is that tearing, migrating pain, but in the elderly, it might just be a faint or hypotension or just some mild chest or back discomfort.
What are the clues?
If you find a difference in blood pressure between their arms, or you hear a new aortic murmur in a hypotensive patient, or the pain is radiating through to the back, you have to launch that investigation for dissection immediately, usually with a CT angiogram.
This brings us to a major hazard the sources highlight, fluid caution. This is a critical warning for trainees. The risks of giving fluids or blood too quickly are huge.
This is so important. Let's focus on the single biggest cause of transfusion-related death and illness right now.
Right.
Transfusion-associated circulatory overload. TACO.
TACO.
We have to risk stratify every single elderly patient for TACO before we give them blood, especially if they're frail or have a history of heart failure.
What's the mechanism? Why are they so vulnerable?
It's the age-related changes to their heart. The left ventricle gets stiff, it loses its compliance. That's diastolic dysfunction. It means it cannot handle a sudden increase in volume.
So it just can't stretch to accommodate the fluid.
Exactly. So you infuse volume too quickly, the stiff heart can't pump it forward, the pressure backs up into the lungs, and they flash into acute pulmonary edema.
So what do we do to prevent that? How do we give blood safely to a high-risk patient?
We go slow. The sources recommend giving a unit of blood over 3.5, maybe even 4 hours, instead of the standard 2. We often give a small dose of a diuretic like furosemide with it, and we do much more frequent observations. Listen to their chest, check their SATs, catch it early.
And this isn't just about blood, it's about any rapid fluid replacement, right? Especially in things like DKA or HHS.
Absolutely. We have to be so careful about giving fluids too quickly in those hyperosmolar states. When their blood is really thick and concentrated, their brain cells have actually shrunk to try and balance things out.
So if we flood them with fluid,
We rapidly dilute their blood, water rushes back into those shrunken brain cells, and you can cause catastrophic cerebral edema.
and it hits the heart too.
Yes. Over-rapid fluid replacement can cause acute heart failure and ARDS. In these really tricky cases, you might even need CVP monitoring to guide you. It is a true tightrope walk between resuscitating them and overloading them.
Okay, let's switch gears into section 3, silver trauma. And that really means falls.
It does. Falls are a major pathway to serious injury and loss of independence for our older patients.
The first and maybe most important instruction in the sources is a philosophical one. We have to avoid the term mechanical fall.
We have to just obliterate that phrase from our vocabulary in the ED. It's a meaningless label. It provides zero explanation, and it shuts down the diagnostic process.
A fall is a symptom.
It's a symptom until proven otherwise. Our job is to figure out why they fell. Was it a real trip, a dizzy spell, a faint? If we just write mechanical fall and send them home, they're just going to fall again.
So that analysis starts with the environment. What are the simple, correctable things we need to be asking about?
You have to ask about the home hazards. Do they have a damaged walker? Loose rugs? Is the lighting bad in their house? Are they wearing unsuitable shoes? These are simple things we can intervene on.
But they're rarely the whole story.
Almost never. The real deep dive is into the medical causes.
So what are the big buckets we need to think about?
I think of it in 3 groups: neurological, cardiovascular, and drug-related. Neurological could be a gait problem from a prior stroke. Cardiovascular could be orthostatic hypotension or an arrhythmia, and then we're back to it again. The side effects of drugs.
The usual suspects again.
Sedatives, antidepressants, strong opioids, blood pressure meds. They are massive contributors to falls.
We also have to get really good at telling the difference between a simple faint and a true seizure, which bystanders often confuse.
This is a huge diagnostic challenge. You'll often get a report of seizure-like twitching. The sources call this convulsive syncope.
What causes that?
It can happen if the person who fainted has a period of low blood flow to the brain, especially if they can't lie flat. But here's the critical point.
It doesn't mean it was a seizure.
Exactly. That brief twitching does not reliably tell you whether it was a seizure or a faint. You have to rely on the history. Before the event, was there warmth, nausea, and the state after the event?
If faints resolve quickly.
Very quickly, with full orientation. A seizure will have a much longer post-ictal period of confusion, maybe muscle soreness, but you have to keep your differential broad. A massive PE can present as a faint.
Right. So when that fall leads to major trauma, the basic principles of CABCD are the same, but managing their system is so much harder.
It is. They are incredibly susceptible to what we call the trauma-induced triad of death.
Which is?
Coagulopathy, acidosis, and hypothermia. And that triad is particularly lethal in older patients because they have zero reserve to fight it.
Let's focus on hypothermia. The sources give some really specific warnings about rewarming them. It's counterintuitive. Why is rewarming them too fast so dangerous?
For mild hypothermia, say a temp above 32 Celsius, passive rewarming is fine. But for a patient with prolonged, significant hypothermia, you must not rewarm them too quickly.
What's the mechanism behind that?
When you rewarm them rapidly from the outside, you cause sudden peripheral vasodilation. All the warm blood from their core rushes out to their cold arms and legs.
Which drops their core pressure.
It causes refractory hypotension. And worse, it shunts all that cold acidotic blood from the periphery back to the heart, which can trigger a lethal arrhythmia. We call it rewarming shock.
So what's the safe rate to aim for?
You need to be slow and controlled. Aim for less than 0.6 degrees Celsius per hour. Gentle, stable correction.
And the drugs we use in a resuscitation, they're not reliable when a patient is cold.
This is vital to remember. Drug metabolism in the liver is completely unpredictable below a core temperature of 30 degrees Celsius.
So the standard doses are meaningless.
They are. And dangerous. If you give a standard dose of a sedative, it won't get metabolized. Then, when the patient rewarms, they're at risk of a massive overdose from the accumulated drug. You have to be incredibly careful.
Okay, so falls lead to fractures, and some of them get missed all the time because we're focused on the big stuff like head bleeds. Let's talk about the isolated pubic ramus fracture.
The classic missed injury. They're incredibly common, usually from a low-impact fall. And they often get overlooked when everyone is rightly worried about a fractured neck of femur.
What's the right way to manage this?
The treatment itself is simple. Good pain control and rest until they can mobilize, usually 3 to 6 weeks. But the key is the disposition. This is not a discharge and forget injury.
So they need a formal referral.
They must be referred to the orthopedics or the elderly care team for coordinated management to make sure they get the physio and support they need to get back on their feet.
And what about spinal injuries? We talk about Suwara in kids, but it's a bit different in the elderly.
It is. In older patients, a spinal cord injury can happen without any fracture on an X-ray or CT because of their pre-existing degenerative disease. A minor trauma can cause a disc to prolapse into the cord.
So we need a high index of suspicion even with normal imaging.
Absolutely. You have to carefully assess for any transient neurological symptoms, numbness, weakness after any fall.
Lastly in this section, nerve blocks. They're great for pain, but there's a specific caution in the elderly.
Nerve blocks are fantastic tools, but we have to be extremely cautious with the total dose of local anesthetic we use. The elderly are at a much higher risk of local anesthetic systemic toxicity, or LAST.
Why is their risk higher?
Their liver function is reduced, so they don't clear the drugs as efficiently. We had to meticulously calculate the maximum safe dose based on their weight and watch them like a hawk for early signs of toxicity.
What are those early signs?
Things like a metallic taste, ringing in the ears, lightheadedness. It can rapidly progress to seizures and cardiac arrest. You have to be ready to treat it with lipid emulsion therapy immediately.
Okay, our final section. Let's focus on disposition, risk, and bringing it all together. First, let's revisit the UTI. How do we solidify the presentation that should make us suspicious?
Right. It's a clinical diagnosis. You should suspect a UTI if an elderly person with no other obvious source of infection has 2 or more of the classic symptoms: dysuria, frequency, flank pain AD, critically new or worsening confusion.
So the confusion needs some localizing symptoms to go with it.
Ideally, yes. That's what makes the diagnosis much more secure.
Then the sources deliver a really critical diagnostic point that needs to change practice, and that's about using urine dipsticks.
This is a firm, evidence-based instruction. Do not use urinalysis dipsticks to diagnose a UTI in older patients.
Why not?
Because asymptomatic bacteria, just having bacteria in the urine without any symptoms, is incredibly common in this population. It can be up to 50% in people who live in nursing homes.
So a positive dipstick is basically meaningless. It's a red herring.
It is. And treating those meaningless positive dipsticks leads to massive overuse of antibiotics, it drives resistance, and it puts the patient at risk of side effects like C. diff.
So what's the right process?
If you clinically suspect a UTI based on their symptoms, you send a proper midstream urine sample for culture, and you treat them empirically with first-line antibiotics until you get that culture result back.
And for patients with a long-term catheter.
The rule is even stricter. Do not treat asymptomatic bacteria in a catheterized patient with antibiotics, ever. You only treat them if they are clearly symptomatic. Otherwise, you're just breeding superbugs.
All right, let's talk about the final, most difficult decision. Discharge or admit. It all starts with checking their mental state.
It has to. You must assess their mental state and check their capacity to make that decision. If a patient is insisting they can cope, but you have real doubts, you have to go back to getting that external information.
The collateral history.
Yes, you have to get that crucial objective insight from family, their GP, community services. You need the full picture before you can sign off on a discharge. If you have any significant doubt about their safety, the threshold for admission should be incredibly low.
And that discharge plan has to include a proper pathway for injuries like those pubic ramus fractures we talked about.
Absolutely not. They can't just go home with a prescription. Those stable pelvic injuries need a formal referral to ortho or the elderly care team to ensure they get proper follow-up, analgesia, and mobility support.
Ultimately, all the sources guide us to one core principle when we're in doubt.
Adopt a low threshold for senior help and for admission. That's the safety net. For any junior clinician facing a complex presentation, that vague abdominal pain, that unexplained fall, if you are in doubt, ask for help and get them admitted for observation. It is always the safest path.
You're protecting the patient from deteriorating after they've left the hospital.
Exactly.
So what does this all mean? We've spent this whole deep dive synthesizing these high-stakes guidelines into something practical for the ED.
The key takeaways for me are about vigilance, proactive assessment, and caution. So vigilance for those atypical sepsis presentations. Vigilance in recognizing a fall as a symptom, never just an accident.
And that critical caution around fluid administration, mitigating the risk of TACO, preventing cerebral edema, and finally, that need for a thorough social and cognitive assessment before they ever leave.
Right. We've established that this is about turning that ED visit into a moment of prevention. We kept coming back to drug side effects as a cause of confusion and falls. That means we have a proactive role to play.
So let's leave our listeners with our final provocative thought. Given that polypharmacy and drug side effects are such common and correctable causes of the very things that bring elderly patients to the ED, how might routinely checking the Beers criteria, that list of potentially inappropriate medications, become a mandatory step in your initial clerking of every single elderly admission?
Think about that. How do we turn that high-pressure ED encounter into a powerful moment of primary prevention? To stop the next fall before it ever happens, we're not just treating today's crisis, we're trying to safeguard their future.